welcome to the FlightBridgeED Podcast series. Hey guys, this is Eric with you with FlightBridgeED. Today I'm going to take about 10 minutes of your time and I want to talk about a new topic that I'm becoming very passionate about, and that is proper sedation and pain management when we have our intubated patients. I know I've done a podcast on RSI, I did a 3-part podcast on RSI, I've done a podcast on sedation and pain management, and I hit that pretty hard, but I still feel like based on the charts I'm reading out there in the industry, the interactions I'm having with flight crews and interactions I'm having with receiving physicians at our trauma centers, we're still missing the boat. Ironically, I'm starting a collaboration research project with a colleague of mine where we're going to look at data throughout the country in the HIMSS industry as it relates to this exact topic. Are we giving proper amounts of pain management and sedation if in conjunction with long-acting paralysis? And I have to say, or I have to argue, we're not. Ironically, also, there was just a recent research project that was published in the Air Medical Journal in the July-August 2013 issue, and it was called Long-Acting Neuromuscular Blocker Use During Pre-Hospital Transport of the Trauma Patient. And what they looked at 105 patients, and after exclusion criteria and things like that, there was only 51 patients. So it wasn't a huge sample. It was actually pretty small. But what they found from that 51 patient sample was pretty profound. 80% or 82% of the patients that were RSI'd and intubated were giving long-acting paralytics post-intubation. Of those 82%, what they found was two things. In a large group of those patients, they received zero to very little sedation and pain management after that long-acting paralytic was given. The other thing that they got from the study was patients that were giving a long-acting paralytic, as in norcuron or vecuronium, their sedation and pain management was treated much slower. So what do I mean by that? In patients that were just intubated with a normal RSI procedure and not giving long-acting paralytics, but treated with, let's say, fentanyl and Versed or some type of sedative medication, that sedative medication was given within 7 minutes of the RSI procedure. On the contrary, if we looked at that same group, but you had the group that was given the long-acting paralytic after intubation, that same subset of patients, it took 16 minutes for the clinician to identify that the patient needed sedation and pain management, and it still wasn't very adequate. So what does this all mean? Well, I have taught this recently in multiple arenas, how we are doing a poor job industry-wide managing our patients' pain and sedation. I talk to flight crews, I talk to paramedics and nurses, and what I've found is there's a huge difference. You have these flight crew members that have flown for years. They have a wealth of knowledge. They've flown thousands of patient flights. But those are the flight crew members that still are stuck in the old days. When I first started flying, when I first started working in an EMS, we gave rocuronium, or VEC, I should say, on every single intubated patient. If we RSI'd a patient, that was the first thing we gave, and then we gave a little bit of Versed. And that time has changed. And what we've identified through research, and there's many research projects that you can refer to, that we do a poor job making our patients comfortable as it relates to the pain aspect. And because of that, our patients suffer, and that's very barbaric care. So what we have to remember is the biggest aspect of having our patients intubated is we have to treat the pain. We treat the pain with fentanyl. Fentanyl is an excellent medication that's gonna decrease that sympathetic response. It's gonna blunt that. It's gonna give you a great analgesic effect. You can give it at high doses. You get sedative effects with higher doses. So I'm saying greater than 3 mics per kilo, and you have great pain management aspects. And then we need to think about a benzodiazepine. We have to think about the sedation aspect. And we can either do that in two ways. We can do that in the aspect of Versed, or we can use a medication like ketamine. So let's use those two for an example. Versed, remember, is a great benzodiazepine medication. It's got great sedative effects, but the problem is it can cause some hemodynamic instability. It can drop the blood pressure. So if you're going to give that in some higher doses, make sure you fill the tank, give a fluid challenge, make sure you have the blood pressure that can handle it. On the contrary, you have a medication like ketamine, and ketamine is a great medication given in that context because it's very stable on blood pressure. It's got great analgesic effects. It's got great sedative effects. And it also has a great bronchodilatory effect, so it works on the lungs. It's a beta-2 medication. I challenge each and every one of you guys to start treating the pain and sedation aggressively, and I promise you if you do this, and I'm saying this because I've practiced this, if you do this aggressively, if you give these medications in a timely manner more often than you're doing it, you're never going to have to go to those long-acting paralytics. And I guarantee you probably 9 out of 10, you could probably stay away from that medication. I just left a board meeting when I talked to a receiving trauma surgeon. And one of the things she had said was there's many times recently where flight crews have delivered patients in the state of Kentucky. She didn't name the company, but that had Norcuron on board, and there was very little sedation, no pain management. The patient had a tachycardic rate, had a high blood pressure, was sweating, and was in obvious pain. And again, that is barbaric care, and we have to remember that. I guess we always have to have a reason why we're giving a medication. And if you're giving a long-acting paralytic like Rock or Vec just because that's what you've always done, or because you just don't want to mess with your patient, or if you just feel like you can manage your patient better that way, that's the wrong way to approach it. We need to be managing our patients correctly. We need to be thinking about how we're going to care for our patients. Remember, we're supposed to be the patient advocate. So give them the pain management dose of fentanyl. Give them a good sedation dose of Versed. Do that often and see what happens. And stay away from that long-acting paralytic. Obviously, there's a use for Vec and Rock. There's always those patients that eat through the medications that need a longer-acting paralytic just to keep the flight crew member safe, to keep the patient safe from themselves. And I understand that, and I understand there's a need. The biggest thing from these studies is showing that because we give these long-acting paralytics, we forget about the sedation. We forget. Our patients are laying there. They're not moving. They have, they can't blink. They can't do anything. So we have no way to identify their sedation status, and we forget about it. We're human. So again, I'm not going to keep ranting on that. We just have to be kind to our patients. Treat with the pain management dose of fentanyl. Treat with a good dose of Versed. And then if you have to, at all costs, if you have to give a long-acting paralytic, then do so. But I challenge you that you won't. If you want to reference this article, again, it's in the July-August edition of the Air Medical Journal. It's on page 203. Again, it's called Long-Acting Neuromuscular Blocker Use During Pre-Hospital Transport of the Trauma Patient. It's very interesting. They've got some great findings from this research project, and I think you'll enjoy reading it. So that's all I have for this. Again, like I said, it was going to be a short, quick podcast. I hope you enjoyed it. If you have any comments, feel free to email me at eric@flightbridgeed.com. Hopefully I didn't rub anybody the wrong way, but these are my feelings. I'm very passionate about this. I feel like we are doing a disservice to our patients by not approaching patient care in this manner, and I think we can do better. So again, if you have any comments, please email me, and we want to thank you for following FlightBridgeED. This year has been amazing. FlightBridgeED has been very successful, and that's because of you, the listeners. It's been way beyond what I ever could have imagined. So I want to thank you so much. It's been very rewarding. We currently have a review, CFR and FPC review guide on sale now on our website. It's going to be also on sale on Amazon.com and throughout bookstores throughout the United States. So be looking for that. And it's a very intensive review guide that goes through every system, critical care-wise, as it relates to those advanced certification exams. It's got rationale, it's got questions, it's got everything. So check that out, and we want to thank you again. Talk to you soon. We want to thank you for following FlightBridgeED.